about post-surgical appearances. Post-surgical complication?
Hello, everybody. I am Gaurav Khatri from UT Southwestern Medical Center in Dallas, Texas. Thank you for the opportunity to speak with you today. I apologize for not being there in person, but I appreciate the invitation, and thank you especially to Dr. Rania and Dr. Fauzi for this opportunity. This talk is on pelvic floor postoperative complications, where to start. I have no pertinent disclosures. So we'll be talking about various pelvic floor repair procedures, as well as imaging techniques to evaluate those repair procedures. And then we'll go through a number of clinical cases or scenarios to show you how we can use imaging to evaluate certain complications. So there's various types of pelvic floor surgery that can be thought of as surgery for either stress urinary incontinence or for pelvic organ prolapse. For stress urinary incontinence, the procedures include urethral bulking agent placement, placement of urethral slings, and bladder suspension procedures. And then for prolapse, you can have various types of mesh, either transvaginal mesh, which has been taken off the market in the United States by the FDA, or mesh sacrocolpopexy, which is an open mesh procedure performed abdominally. And then there can be various native tissue repair procedures or rectopexy procedure. Today, we'll focus mostly on urethral slings and vaginal mesh. So we can image these patients with either MRI, pelvic floor ultrasound, or in the acute presentation with CT. So here is our institutional MRI pelvic mesh protocol. We start with axial T2 weighted 2D images, as well as coronal and sagittal 2D T2 weighted images. And then we do one 2D T2 in one single plane with fat suppression. We typically do that in the sagittal plane. You can also do a 3D T2 weighted image, and this should be isovoxel, either 1 or 2 millimeter. And then we do axial T1 weighted gradient echo in and out of phase images. And then we, in most cases, choose to do pre and post contrast T1 weighted images as well. Although that is not always needed, it does help detect areas of inflammation in more subtle cases. How about the ultrasound? So we use a transperineal ultrasound at our institution, and here you can see the probe placement and the sagittal and transverse images. Here is the anatomic landmarks that we use. Anteriorly on the sagittal image is the pubic symphysis, followed by the hypoechoic tubular structure which is the urethra. In the far field is the urinary bladder, and then behind the urethra is the vagina. And typically, the sling will live between the urethra and the vagina. On the coronal image, you see again this tubular structure, which is hypoechoic, is the urethra, and then in the deep field is the urinary bladder. There are two main types of urethral slings, retropubic sling and transobturator sling. As the name suggests, the retropubic sling has its arms extending anteriorly between the bladder and the pubic bone in the retropubic space. Meanwhile, the transobturator slings, the arms are extending more laterally through the obturator foramen and do not go into the retropubic space. Here's what a normal appearing retropubic sling looks like on ultrasound. So here's the pubic symphysis on the sagittal ultrasound. This is the urethra. And then behind the urethra, like just along the posterior wall of the urethra, is echogenic structure, which is the sling. And you can see this shadowing because of the synthetic material. And then this is in the midline. If you were to look parasagittal on either right or left, you would see this kind of dot dash or crosshatch type pattern. And this is the weave of the mesh. It looks just like the mesh in real life. And when you see this, you can be 100% sure that this is synthetic mesh and not a biologic mesh. You can see it also sometimes on the transverse image along the posterior wall of the urethra here. Now we can do all kinds of reconstructions. Here, this axial reconstruction can be used to measure the distance of the sling from the urethra. This is what the cine of the urethra looks like. You can see this is the sling coming in with that crosshatch pattern on the one side, and in the midline, it's this linear structure on the back wall of the urethra with shadowing, and then you can see it extending and wrapping around the urethra on the other side as well. So urethra is really good to evaluate the sling components that are very close to the urethral wall. and specifically between the urethral wall and the vagina, because this is very hard to see on the MRI. We can do these volume renderings. In this particular case, you can see the arms going anteriorly because this is a retropubic sling. These arms in this different patient going laterally because this is a trans-obturator sling. You may ask, how good are we at evaluating slings? So the big question typically in these patients is if there's erosion of sling into the urethra or vagina or not. This paper from 2018 performed at UCLA, the study was a retrospective study, and they showed pretty high sensitivity up to 93% and specificity ranging between 72 to 100% for detection of erosion at translabial ultrasound. So here's clinical scenario 1. This patient presenting with recurrent UTI and suspected urethrovaginal fistula 8 years after placement of sling. She wasn't sure what type of sling she had placed, if it was a synthetic sling or a biologic sling. So this is a sagittal cine image, and I'll take you back through it here. And what it shows is that this sling, this echogenic structure, is right in the middle of this hypoechoic tubular structure, which is the urethra. This is the bladder in the far field, but this sling is right in the middle of the urethra. On the coronal image, you'll see something similar, and you see as you scroll through the urethra, the sling is going right through the middle of the urethra, okay? So this is very suspicious for erosion into the urethra. The same patient actually had 2 slings. This is the one that I was showing you going right through the urethra. The second one is much more posterior, going through the vagina. And again, the coronal image is confirming that sling going through the middle of the urethra. Doing the recon at the level of the sling, you can see at this axial recon, the orange arrows are pointing to the extension of the arms going away from the urethra, but the center of the sling is going right through the urethra. So this confirms the erosion into the wall of the urethra, and this was in fact confirmed at surgery. This was synthetic mid-urethral sling perforating into the urethra. Okay. How about MRI? How good are we with MRI? So MRI is better for portions of the sling that are away from the urethra. So, for example, this retropubic sling, the arms that are in the retropubic space are seen better on MRI than on ultrasound because the ultrasound is not able to penetrate through the pubic bone. The trans-obturator sling can be tougher to see on MRI. However, sometimes you can see it with the arms extending laterally through the obturator foramen. This is a normal retropubic sling. You can see the arm right by the pubic bone here on either side. On the sagittal image, you can sometimes see the entire arm coursing. It's this thin, linear, hypo-intense structure on T2 weighted images going through the rectus fascia into the suprapubic fat. On the coronal image, very important, you want to see this to be on either side of midline, okay? It should be like this thin, slit-like structure between the bladder and the pubic bone. You should have fat between the lesion, between the sling and the bladder. It should not be sitting right up against the bladder. If it's right up against the bladder or causing bladder wall thickening, you have to worry about bladder erosion. So clinical scenario 2 here, patient comes into the ER with gross hematuria and left lower quadrant pain and severe leukocytosis. That was the only history that was provided. This patient has what was called a large inflammatory mass involving the bladder and involving the rectus abdominis on the left. On the sagittal image, you can see again this mass involving the bladder with extension to the rectus abdominis. And so on CT, this was called large inflammatory mass. Patient went to cystoscopy 2 days later, where this quote-unquote mass was biopsied, and it showed benign urothelium with acute/chronic inflammation and dense eosinophilic infiltrate. There was no evidence for malignancy. So patient was followed, got an MRI 1 month later, and now we're seeing largely that mass has resolved. What's left is this linear hyperenhancing structure that's right against the wall of the bladder. This is inflamed urethral sling with erosion to the bladder, and you can see some residual inflammation at the rectus abdominis as well. So this was a retropubic sling with bladder erosion with marked cystitis resulting in an inflammatory mass on the initial presentation. This case was sent to me by one of our prior fellows and colleagues who moved to a different practice and saw this abnormality and sent it to us because this is where he learned how to read these cases. All right, next clinical scenario, a patient with pubic pain, relatively short time interval, 5 to 6 weeks after placement of sling. Patient also had a uterosacral ligament suspension done. So playing this video, You can see there's something asymmetric on the right side of the pelvis, and then there's this soft tissue density tubular structure going towards the pubic, the skin surface. So here's the asymmetric thickening on the right in the pelvis, maybe involving the rectum, and then as we keep coming down, we see this tubular structure that's going through the rectus abdominis, going right on top of the pubic symphysis, which has a lot of soft tissue and erosions, but this structure extends into the mons pubis and to the skin surface here. So again, the static image is showing the abnormality along the right side of the pelvis and the erosion of the pubic symphysis and this structure going right next to pubic symphysis extending into the mons pubis. MRI was then performed, and again you can see this inflammation in the right side of the pelvis, and you can see this fluid signal intensity structure now that's extending through the rectus abdominis, and it's causing a lot of edema also of the pubic symphysis here. On the coronal T2 fat suppressed image, same findings, where we can see that there is inflammation of the rectum, asymmetric inflammation on the right side of the pelvis, and then we see this tubular structure that's extending right on top of the pubic symphysis, going through the rectus abdominis, and then it's actually extending in the mons pubis to the skin surface there as a fistula. On the sagittal image as well, same findings. You can see this enlarged structure going in the midline, where a retropubic sling should be on one side of midline, not right in the middle of the midline. And this is going through the, at least touching the pubic symphysis here, and then going to the skin surface. So this is a fistula causing osteomyelitis of the pubic symphysis. For comparison, this is the right side of the sling, which looks more normal. And so let's look at some static images. Right pelvic inflammation from the uterosacral ligament suspension. And then this is the pubic symphysis abnormality with edema, osteomyelitis. And this is the malpositioning of the sling, which is placed in the midline as opposed to on the right, on the left side. So again, just to bring this all case together, this is the right arm of the retropubic sling. This is normal, okay? And the green arrow is showing a normal right arm of the sling, which is also shown on this T1 coronal image, normal, very thin hypoechoic curvilinear appearance of the right arm of the sling. And you can notice it's on the right side of midline. The left arm of the sling with the yellow arrow actually is in the wrong place. It's in the midline, sitting right on top of the pubic bone, causing all this erosion and osteomyelitis of the pubic bone. On the sagittal T2, again, you can see the edema and high signal intensity along the course of this malpositioned sling with concomitant edema and osteomyelitis of the pubic symphysis. So this was malpositioned urethral sling with pubic symphysis osteomyelitis causing a fistula, and there was also infected right uterosacral ligament suspension. This is what the suspected diagnosis in this patient is. All right, so to confirm a urethral sling placement, you can start with pelvic floor ultrasound. MRI can be less sensitive to detect slings. To evaluate for urethral or vaginal erosion, you may do cystoscopy or vaginoscopy, and if you need additional imaging, pelvic floor ultrasound is the way to go. To evaluate for bladder symptoms, pubic pain, generalized pelvic pain, or possible abscess or hematoma, which can occur acutely after sling placement, you look at CT or MRI. And then moving on to prolapse repair. Prolapse repair with mesh can be done with transvaginal mesh or with mesh sacrocopopexy. The transvaginal mesh is placed through an incision in the vagina, has a much higher risk for erosion. For that reason, has been taken off the market by the FDA. The mesh sacrocopopexy is placed abdominally, and it extends from the sacropromontory to the vaginal apex and has a less risk for erosion. So here's a patient that does not have any vaginal mesh. This is normal appearance of the vagina on the sagittal and the axial image. This is a patient with a normal mesh, anterior vaginal wall mesh, and posterior vaginal wall mesh. You can see these thin linear hypoechoic structures on either side of the vagina, on the sagittal, on the axial image as well. And laterally, these arms extend through the levator muscles in this particular patient, extending into the ischiorrectal fossa. So this is normal appearance of transvaginal mesh. This patient had transvaginal mesh, but was presenting with vaginal discharge. So if you watch this video, you can see the normal right side of the mesh between the rectum and the posterior vaginal wall. This is posterior vaginal mesh, but the left side is much thicker and much more abnormal looking. You can see it's right up against the posterior wall of the vagina and much thicker. So this was suspicious for vaginal erosion on the left side of the posterior vaginal mesh. And looking at the static images on this patient, you can see the right arm is normal, left arm is very thick here behind the posterior vaginal wall, and the vaginoscopy in fact confirmed that this was transvaginal mesh erosion along the posterior vaginal wall on the left. A different patient here with perineal drainage after prior pelvic surgery, wasn't sure what was done. You can see this really mass-like thickening along the anterior vaginal wall. If you look at it on the sagittal T2 weighted images along more laterally, this was contiguous and extending into these multiple branching fistulae. And then you look along the anterior vaginal wall, this was eroded into the anterior vaginal wall, causing multiple fistulae. So this was anterior vaginal mesh causing anterior vaginal wall erosion with multiple fistulae extending into the left perineum. This is normal appearance of this sacrocolpopexy mesh going from the sacral promontory to the vaginal apex on the coronal image, and also on the sagittal image. It should be nice and thin, just like this. In contrast, here's a patient that presented with an infection after sacrocolpopexy mesh placement. Very thick mesh. You can see there's some high signal intensity on T2, both on the coronal and the sagittal image. You see how thick this is compared to the other one I showed you. On the axial image, it looks very, very thick and rounded, almost mimics a bowel loop. So be careful about that. If this can be followed to the sacral promontory, this is not a bowel loop. This is sacrocolpopexy mesh. This is an infected mesh. Different patient here showing mesh extending to the sacral promontory with enhancement of the bone there. So this is infected mesh with associated osteomyelitis. So when suspecting osteomyelitis after sacrocolpopexy mesh, you would do an MRI. So if for prolapse mesh complications, to confirm mesh and characterize the type, MRI is probably better than ultrasound. To look for mesh infection, erosion, again, if you're in the acute setting, you may get a CT scan. Later on, you may get an MRI. Vaginoscopy can certainly show the erosion into the vagina as well. Looking for fistulae or osteomyelitis, again, in the acute setting, you may start with CT, but then eventually you may need an MRI. All right, so this is a patient that had prior prolapse repair and now presenting with a new posterior bulge. So this is a defecography before the repair, and on this defecography, you can see the cystocele going between the urethra and the vagina. So this is a cystocele at baseline that this patient had. And then after this, the patient had what's called an anterior vaginal wall suspension, and that is using suture material from the anterior vaginal wall that is tied in the suprapubic fat. This is not using mesh. This is just anterior vaginal wall suspension with suture. And so this is after the procedure. You can see on the sagittal T2, this is the suture material here going between the bladder and the pubic symphysis, and it's tied in the suprapubic fat. But then patient presented with prolapse again. So patient presented with posterior prolapse behind the vagina. It was suspected to be enterocele or rectocele, but as we look at the defecography, we actually see the bladder is what's prolapsing behind the vagina. So this is a very unusual case because the vagina was pulled anteriorly from the anterior vaginal wall suspension. There was prolapse of the bladder behind the vagina. So this is the baseline defecation. You can see the urethra is actually horizontal. The bladder is prolapsing between the urethra and the vagina, which is also descending. And then patient had the anterior vaginal wall suspension. And then you can see the vagina is now pulled anteriorly, which is supporting the urethra, but the cystocele is now going behind the vagina, which is very, very unusual. And so the MR defecography was instrumental in demonstrating what was going on here. So if you have patients that present for recurrent prolapse after surgery, you may do an MR defecography. In certain cases, a fluoroscopic defecography may be beneficial as well. So to summarize, for urethral slings, you start with either pelvic floor ultrasound, or you may get an MRI depending on the suspected complication. For prolapse mesh, you tend to go more with the MRI, may get a CT in the acute setting, and then for recurrent prolapse, you can do either MR or fluoroscopic defecography. Thank you so much for your attention. And I'd like to acknowledge my pelvic floor imaging and clinical team that we work closely with at UT Southwestern. Thank you so much.
Thank you so much, Gaurav, for that fantastic lecture on complications post-surgical. I've got one question, just logistic really. In the patients with slings, do you do ultrasound and MRI as a one-stop, or you call them later, or how do you sort it?
Usually, depending on so one of our urologists orders a lot of these examinations. They usually, for slings, will start with ultrasound. And then if the ultrasound is not able to explain the clinical symptoms, they may get an MR later in a select group of patients. We don't do it together. The MR is better for the sling, that is the components of the sling or the arms that are more distant, not right up between the urethra and the vagina. If the indication is voiding difficulty and they're thinking the sling may be too tight or eroding into the urethra, or maybe there's suspicion for vaginal erosion, they'll start with an ultrasound. But if for some reason it's more of a pelvic pain or anterior pelvic pain, they're worried more about infection of the bladder, where the sling may be eroding into the bladder more peripherally, they'll get an MRI. But typically they're separate.
Yeah, thank you. Are there any questions from the audience?
Yes, please, Dr. Hussein. تفضل. ممكن الميكروفون لو سمحت؟
Thank you very much, Professor, for this exquisite presentation. I would like to ask you a question about how many patients do they complain of post-mesh application, for instance, pain during intercourse or urinary problem like dribbling or pain during micturition? Whether mesh application or strings or strings, yeah.
Slings, yeah. I will say that
is it common or you could tell us?
We see multiple patients of this, I would say, in a month, and sometimes, at least one a week, if not more. But that's because we have one specific urologist who is kind of a tertiary referral center throughout the whole country for these kind of problems. There's a few people around the United States that help these patients, and he happens to be one of them. So our population is certainly biased. We get more common exposure to this than most other places. I will say that in the literature, as far as the rate of complications, the transvaginal mesh has been reported to have a complication of erosion in as high as 18% of cases, very high. And so that's why the FDA in the United States has taken that product off the market. Now, the sacrocolpopexy mesh, the incidence of erosion is much lower. It's about 2% or 2 to 3%. So, if that gives you an idea, somewhere in that range is probably the incidence of complications in these patients.
Thank you.
Okay, thank you, Gaurav. I can't thank you enough to joining me from US, and I know how it's hard for you to keep that with the question. Thank you very much for your attendance, and I hope next year you will be here.
I hope so too. Sorry I was not able to make it this year, but thank you so much.
Okay, thank you, Gaurav. We have a symposium from Mind Ray